I think the waiting room is starting to slow down, so I'll keep an eye on it. But if you want to go ahead and get us started.
Great. Thank you very much. Good afternoon, everyone. Welcome to the April series of our West Virginia University Center for Excellence in Disabilities Abilities Grand Rounds. Today we have a very special topic, including people with disabilities in healthcare training. This is something near and dear to our hearts here at the center, as well as for our partners, and we really appreciate you joining us this afternoon. Before I introduce our speaker, just as a quick reminder, make sure that your background is muted for the time being. However, please do not take that as a sign that we don't want to hear your questions, comments, and other thoughts. Feel free to put that in the chat or raise your hand. Anyway, we're going to be monitoring all of those things as Dr. Havercamp does her presentation. I will make sure that time is given to your question or thought. So please do that. We just want to make sure that everyone can hear and it's clear for everyone as we move forward. So with that, let me go ahead and introduce Dr. Havercamp. She has a wonderful background. She's the director of the Health Promotion and Healthcare Parity Program at the Ohio State University in the Neisinger Center. So that, if you're not familiar with the UCED network, that is our equivalent facility. That's the UCED in Ohio. So we welcome our partner here. She's a consulting editor for intellectual and developmental disabilities and inclusion, and the book review editor for the Journal on Mental Health Research in Intellectual Disabilities. In addition, she's the chair of the research committee for the National Association for Dual Diagnosis, on the board of directors of the Alliance for Disability and Healthcare Education and Human Services Research Institute. Her research focuses on physical and mental health issues in people with disabilities. She provides disability training for healthcare providers and serves as the disability issue representative to the Group on Diversity and Inclusion at the Association of American Medical Colleges, or AAMC. Dr. Havercamp directs a program to increase the state's capacity to promote health, prevent chronic disease, and improve emergency preparedness and quality of life for Ohioans with disabilities. And I look forward to hearing your presentation, Dr. Havercamp. With that, I'll turn it over to you.
Wonderful. Gosh, thank you so much, Dr. Critchwell, for that wonderful introduction. I am really thrilled to be here talking with you today. Disability training and engaging with the disability community in research and training activities is one of my very favorite parts of my job. I'm really happy to be here talking with you about it today, and look forward to hearing from you and how you've been able to engage with people with disability in education and other program activities this afternoon. Yeah, before I get started, in your introduction, you mentioned this project. I co-direct the Ohio Disability and Health Partnership, and this is a program that's supported by the Centers for Disease Control and Prevention, and it's really designed to build the state's capacity to provide health and healthcare to people with disabilities. So we engage in health promotion initiatives as well as healthcare training and health surveillance. And I'll tell you a little bit about some of our activities throughout my presentation. But I want to express my gratitude to the CDC for supporting me and allowing me to be here today. One other thing that I'll say about this partnership is that Ohio State University Neisinger Center, that's where I am, but we partner really closely with our Department of Health for the state. Ohio has 2 UCEDs, so we partner with our sister UCED in Cincinnati, as well as with the Government Resource Center, which is a really innovative research center in Ohio that kind of provides services and support to the 6 colleges of medicine in the state to help raise the level of research, particularly health surveillance research, and provide information to the colleges and to our state programs. So we're really lucky to have this partnership, and We also have a large advisory committee that we partner with that really informs our work, made up of about 100 people with disabilities, family members, and disability-facing organizations. That really drives our work in this program. So after today, my goals for today are, I'll tell you about why I think it's important to provide disability training to healthcare providers. I hope you'll be able to discuss the needs for this training and understand why I spend so much time doing it. Also talk about what it is we need to teach healthcare providers about disability, and how that informs the quality of healthcare that they provide. And then I really look forward to talking about some promising strategies that we've tried here at Ohio State University, and some strategies that have been published in the field. And I understand that West Virginia University has really been on the cutting edge of disability training. And I look forward to really having a conversation with you about what strategies you've tried and what you found successful in your programs. So to start, why do healthcare providers need disability training? Why are we even talking about this? And this, I don't know, this may be news to you, or it's maybe something that you're really familiar with, but there's been a series of studies asking healthcare providers, asking healthcare students, asking disabled people about their healthcare and about their comfort in providing care to people with disabilities. In 2020, there was a large survey of members of the American Academy of Family Physicians, so family medicine providers, and only 36% of the people responding to that survey reported that the training that they received on disability was adequate to provide high quality care to patients with disabilities. And in fact, 97 of respondents said that they really needed to learn more about caring for patients with disabilities. So that to me is a really strong testament. If the physicians themselves are saying, or the medical students themselves are saying, I really haven't learned about that, I wouldn't know what to do, that's a testament. Specifically asking about the type of training, the type of experiences that they had with disability, there were 4 things that were really glaringly absent from the training programs. One was engaging with people who had disabilities. So they reported that they really did not have an opportunity in their training to meet patients with disabilities, to learn from people with disabilities, to do any kind of simulation or practice with that population. They reported, in addition to that, they reported that they had really no basis to make accommodations in a physical exam and interacting with a patient who had a disability. They said that they really wouldn't know where to start to try to accommodate that patient in the exam. They didn't know anything about, and were kind of surprised by the question about physical activity for disabled patients. They drew a blank on knowing where to refer people or what to say with respect to recommending physical activity for patients with disabilities. And they reported they had not had an opportunity to learn from a faculty member who is disabled. So those 4 things, the authors of this article highlighted those 4 things in particular as a real gap in opportunities for students to gain confidence and comfort in caring for this population. In another survey, this was a really large survey, went out nationally to across the United States, directed at physicians in like 6 different specialty areas. I believe family medicine practitioners, dentists, gosh, I'm gonna blank on the other specialties, but the OBGYN was included, and the idea was to include physicians who were both likely to have patients with disabilities and but not necessarily specialize in caring for patients with disabilities. Of the national sample, 40% of the sample reported that they felt really confident in their ability to provide the same quality care to patients with disabilities as they do to patients who don't have disabilities. Only 56% felt that they really welcomed patients with disabilities into their practices. And the vast majority of them, over 80%, said that they believe that people with disabilities had significantly worse quality of life compared to people who didn't have disabilities. And I'm going to come back to that. I think that belief is really important and problematic in caring for patients with disabilities. And so overall, the authors of this study concluded that these numbers are concerning. You know, if only 40% of physicians are confident in caring for this population, that explains why people with disabilities say that they have a terrible time finding a healthcare provider. They call practice after practice and hear that the physician really doesn't see patients with mobility limitations, for example. They really don't feel confident providing that care, and you should find a different provider. The problem being that there isn't a specialty in medicine for caring for patients who have disabilities, particularly in primary care or specialty care, actually, both. Without this training, or without specific intentional disability training, healthcare providers, you know, like most people, I think, hold assumptions about disability. Most people, unless they have a family member, a close friend with a disability, they really can't imagine life with a disability. They can't imagine if they were to have an accident or an illness tomorrow and to lose function, to acquire a disability. Just that thought exercise, I think the first thing that comes to mind is all of the things that you enjoy doing, all of the ways that you do things. And your first thought is, gosh, I wouldn't be able to take long walks with my dog anymore. I wouldn't be able to drive. You know, I wouldn't be able to contribute into the community in the way that I do now. And without being able to contribute, my life would be less, it would have less meaning, and I would have a lower quality of life. And that's just a really quick thought exercise. And you very quickly come to the conclusion that having a disability would mean that I would, my quality of life, my meaning would be compromised. The problem with that is, the problem with taking that exercise and applying it to people who have disabilities is that it's not true. When you ask people with disabilities about their quality of life, they report roughly the same quality of life as non-disabled people, because people adapt and you find meanings in other ways and other things, and you find different ways of doing the things that are meaningful to you. The other reason that it's problematic is that if I assume that my patient has a lower quality of life, that's going to affect my clinical decision-making on behalf of that patient. It's going to automatically, unconsciously affect the choices that I consider, the treatment options that I consider for that patient, and the treatment options that I offer to that patient. I'm automatically making decisions based on that erroneous and dangerous belief. So, so these assumptions are worrisome, and I think recognizing that the best way to challenge them and really to change those assumptions is to provide accurate information and experiences in healthcare training. And that to me, that's the most important reason for offering disability training in healthcare education. Sorry, my slide stuck. Okay, here I'm back. Actually, it was the same author group. They published studies in health affairs recently, and they did this large national survey of physicians and 8 different specialties, asking about their experience with patients with disabilities. Then they did a series of focus groups with physicians. And so these are small groups of physicians talking about patients with disabilities. And what they found through these focus groups was that physicians had really significant barriers. They presented and described physical, communication, knowledge, structural and attitudinal barriers to care that would affect patients with disabilities. So just for a couple of examples that came out of the focus groups, one physician said, well, and not even knowing myself what would be best kind of care. I mean, what's the best equipment for them? I don't even know. I'm not even qualified. So that really illustrates this physician. She's clearly not had any training or exposure, and just thinking about trying to provide care to a patient with a disability is kind of overwhelming. And she's saying that she doesn't know how to do it and she's not qualified to do it. And I think a lot of providers assume or fervently hope that there's someone else out there who is qualified, who does know how to do that, who does have an accessible practice, who is able to accommodate patients with disabilities. And unfortunately, that is not true. One provider said, people with disabilities can create a big thing out of nothing. Kind of expressing frustration about, I didn't pull this quote, but a couple of physicians expressed frustration about the requirements under the Americans with Disabilities Act, which, as you may know, does require healthcare providers, both public and private, to accommodate patients with disabilities. And they've said that is really difficult and unfair to them as a business owner in private practice. And finally, the provider said, well, I know for a fact that our building's not accessible. I didn't pull this quote, but another thing that came out of one of these articles was a lack of understanding of what their requirements are under the Americans with Disabilities Act, and a belief that they were at risk for a lawsuit because they are pretty sure whatever the guidelines are, they're not meeting them. So I think, not just me, it's likely that the lack of training, the lack of comfort and confidence in providing care, these erroneous and dangerous beliefs, they lead to worse quality care for disabled patients. And the other thing that is important to know is people with disabilities have worse health. We did a study in Ohio trying to understand the health and health disparities, healthcare needs of Ohioans with disabilities. And for these data, we compared people with and without disability on secondary data sets that were available. So we used a mixed method approach to do this comprehensive statewide needs assessment. These are secondary data analysis from the Ohio Medicaid Assessment Survey, which is a large telephone-based survey of people, not just people on Medicaid, but people across the state. And we asked some questions that allowed us to identify the respondents who had disabilities. And we compared those responses to people who did not have disabilities. And we found people with disabilities had far worse health. They were 13 times compared to people without disabilities, people with disabilities were 13 times more likely to say that they had had 14 or more unhealthy days in the past month. They were 5 times more likely to report their health as fair or poor, as opposed to good or very good. They also had worse mental health. They were 7 times more likely to say that they often feel isolated. Also 7 times more likely to say that they feel left out. And overall, disabled Ohioans reported more unmet healthcare needs. They were 4 times more likely to say that they had unmet needs for mental health treatment, 4 times more likely to have visited the emergency department 3 or more times in the past year. And that's often seen, emergency department use is often seen as an indicator of not receiving adequate primary health care. Because if their chronic health conditions, if their health needs were met routinely, it's less likely that they would visit the ER 3 or more times. So that's why that indicator is really important. And Ohioans with disabilities were 4 times as likely to say that they had delayed or completely avoided needed health care because they couldn't get transportation. So those are huge needs in our state that is important because that drives our program activities. But these are not unique. These findings are really comparable to other studies that have been done at a national level. After the secondary data analysis, we did a series of focus groups and interviews, critical participant interviews with key people in our state. And this is just one quote that we captured from participants in one of our listening sessions, identifying the importance of providing training to healthcare providers. And that recommendation really came up in almost every session that we held. That people with disabilities who participated said that they just really struggled with getting accessible, adequate healthcare and feeling listened to and respected by their healthcare providers. And 201, they called for more training. Okay. However, when disability content is included, students are really very positive. There's a number, a dozen studies probably that got feedback from students after engaging in disability content. And the feedback is really positive. You know, they report learning a lot. They report really changing the way they think about patients with disabilities. And they report that the experience are relevant to their practice and really meaningful to them personally. So the next question is, so what should we teach? You know, I hope I've convinced you, if you're convinced that we need to teach about disability, what exactly do you need to know about disability in order to provide quality care? I'm a member of a national nonprofit group called the Alliance on Disability for Healthcare Education. At the time, 10 years ago or so, this was a really small, maybe 24 member organization, not for profit. Like I said, it was just healthcare educators who were really concerned about the health of people with disabilities and wanted to improve that through training. And so we could talk to each one of us about the training that we provide in our programs to healthcare providers. And one thing that was so interesting is that we were all really passionate and put a lot of energy into this work and felt good about it, but nobody did the same thing. It was so diverse. Some people would do lectures, or they would bring people with disabilities in for a guest lecture or for a patient panel. or they would have students go to the Veterans Administration, so they would have experience with people who had different types of disabilities, or they would have students go to provide a disability provider organization or advocacy organization so they could talk to people with disabilities and learn some things. And we realized that those different experiences are probably all good, but students are learning very different things depending on the kind of encounter that you're providing to them. And we didn't know which was better. We didn't know what the best kind of strategy was. And so we decided in our group that we would prioritize developing a consensus on what it was that healthcare providers needed to know about disability. And that'll help us direct our efforts. So we're developing content that really matters. And we hoped, because we're thinking big, that we would be able to shape curricula in healthcare programs to include disability. And so this is what we did. Let me move my screen so I can see it. So the Ohio Disability and Health Program, my program in Ohio, partnered with the Alliance and really tried to establish what it was that healthcare providers needed to know. We recruited a national sample of people with disabilities, family members of people with disabilities, disability advocates who may or may not be disabled themselves, health educators, healthcare professionals, and disability professionals. Huge group. We recruited them to help us develop the core understandings. What is it essentially that healthcare providers need to understand about disability? And so we kind of drafted what we thought was really important. We, the Alliance for Disability and Healthcare Education, we drafted some learning objectives. We shared them with this national stakeholder group and asked for their feedback. What are we missing? What do you think isn't that important here? What would you change about these learning objectives? We got a lot of feedback. People were really generous in offering their critiques. And we used the feedback to revise the learning objectives. And so we incorporated all of the feedback, revised the learning objectives, and sent it back out to the same people. It's called a Delphi process. It's kind of iterative, where we kept revising the objectives, we kept getting feedback until we reached what we call a consensus. It was, we set a threshold at 90%. I think we got close to 95% of our stakeholder group agreed that the final list of learning objectives were important, were critical to providing quality care for patients with disabilities. They agreed, everything that we really wanted in this list was that they be cross disability. We were careful not to develop a list of competencies for patients who were blind or for patients who had intellectual or developmental disabilities. We thought it was important that these competencies be relevant to all patients with disabilities, regardless of the specific functional limitation that they experienced. We also felt strongly that these competencies should be interdisciplinary. It's not just for physicians, it's not just for psychologists. They're things that every healthcare provider should understand. And so these are the, we call them the core competencies. They're not everything that you should know about disability, but they're kind of a baseline, a fundamental core understanding of disability that will allow you to provide quality care. We also, towards the end of that process, we got some feedback that, you know, the learning objectives are good, but felt like we needed something to kind of string it together. It's not just a question of learning content. It really is important to have a kind of a guiding system of values and principles And so we worked with our stakeholder group and developed some guiding principles and values that drive the competencies. And we landed on 6 core competencies. And these are available online free. There's some links on this page. I'm happy to share them. The first competency has to do with disability framework. We understand that most healthcare providers are exposed, and what they know about disability is from a medical model understanding. They know that disability is a negative health outcome of a lot of health conditions and injuries. They know that there are therapies that can improve function and treatments. But it probably has never occurred to them that people with disabilities have health independent of their disability. And so we felt it was important for healthcare providers in particular to understand disability as a demographic characteristic and not just as a health outcome, so that they could think about improving the health of their patients with disabilities and to recognize social impacts on disability and function. Recognizing that all healthcare training programs have professionalism and patient-centered care kind of content, we thought it was important to identify the specific communication skills, the specific assumptions and errors that take place when caring for patients with disabilities that leave the patient feeling like they really weren't respected or listened to. And so we're trying to help the trainees unlearn some of their habits and provide better person-centered care, helping them recognize the implicit biases that they hold and mitigate those biases. The legal obligations and responsibilities is important. I think the fundamental thing that we try to that we expect our trainees to learn is that accommodations are not just the right thing to do, it's a civil right. And so kind of pushing trainees from thinking of people with disabilities as an entity to be pitied, to feel sorry for, to help out, and then they should be grateful for that help. No, they have a right to healthcare, they have a right to these accommodations, and you have a responsibility to make that change so that you're not presenting barriers to care. Again, team-based learning and systems practice is often a part of healthcare training already. We have some specific competencies around how to make that work for patients with disabilities, in particular, making sure that the disabled patient is not only at the center of the team, but is driving the team. And then finally, there's some specific competencies about clinical assessment and clinical care for patients with disabilities, considerations that may be different than from patients who don't have disabilities. Thank you. So the last series of slides and the last thing I want to talk with you guys about is how can we do that? So we have 6 competencies and 46 sub-competencies. How can we fit that into existing healthcare education? And if you've ever tried to add disability content to an existing program, you may have experienced some pushback. You may have heard things like, well, you know, our curriculum's really full, and I'm not sure that the students really, that training is that important for the students right now. They already learn quite a bit about health conditions. They already learn about trauma and injury and birth defects and prenatal care, and what you're learning as you're experiencing the pushback, is that health educators and healthcare providers see disability as a health condition. Full stop. So they learn and they think about preventing the health condition, mitigating the health condition, treating the health condition. It's really difficult for them to think about people with disabilities as a group. So once you've acquired the disability and you go on to live 30 years, you're no longer treating the disability. You're no longer rehab or therapy. Now you're just living, and you have a functional limitation and you have health. And you may have good health and you may have really lousy health, but I can tell you, unless we do this training, you're going to experience a lot of barriers to health care. And so, in thinking about how to navigate the barriers to getting content into the existing training, I think sharing data with the health educators, with the curriculum deans about the disability population, I think it'll be really surprising to them to learn that 26% of American adults have a disability. They won't believe it. You'll have to pull out the articles and the evidence for that, because in their mind, they just don't see that many disabled people. And they've only thought about it in one narrow context. And so I think talking about the prevalence, talking about the health disparities, helping them see disability as an identity group and not just as a condition, I think that's an important way to try to change the conversation. The next thing that you might hear if you make it this far in the conversation is, well, I don't even know how to recruit disabled people. They're not going to want to come in here and be a standardized patient or talk to our students. And so then you take that as a personal challenge and reach out to your networks and put a flyer on social media, and you'll be amazed how many people with disabilities will call you inside of a week and say, yeah, I want to help educate the healthcare providers. That definitely, they need to learn this, and I would love to be part of it. We've been so fortunate in recruiting hundreds of people willing to come in or Zoom in and talk to students about their experience. The other success that we found, instead of asking for a disability day or disability lecture, which I think kind of marginalizes disability and it may not be the best way to convey the information that we want anyway. We've tried to weave disability through the curriculum by identifying disability as a marginalized identity group, by saying whenever you talk about health disparities, population health, social determinants of health, disparate populations, disability fits right in there because they experience the same barriers and then some. And so you can talk about the impact of social determinants on Black, low income, migrant, and disabled groups. It doesn't have to be a lot of time. It's just a little bit of a stretch. But to pull that off well, and this is the last thing I'll say here, I really think that we need some professional development for the faculty. This is a new way for them to think about this population, and in order for them to be comfortable sharing that content and for them not to reiterate some of the inaccurate and dangerous assumptions that and biases that most of society hold. I think we really need intentional professional development to prepare them to convey this content. Okay. So there's 3 levels, and I encourage you all to target all 3. They're not mutually exclusive for sure, but there is a lot of literature. There are a lot of examples of people creating a course or a clinical opportunity and offering them to students as an elective. This is the easiest ask. If you were trying to get content into the curriculum, asking for an elective asking for a one-off is you have the best chance of winning that. And it may be a really good place to start. So disability-focused guest lecture or panel, video. The limitation clearly is that only students who have some interest in disability will likely take that elective. And so you won't be reaching most students or likely the students who really need to rethink their assumptions. At a program or university level, the next harder task would be embedding some required content throughout the curriculum, not just a one-off, but a thread, if you can wed it with a diversity thread or with population health. If you can hire faculty members who identify as disabled, if you can recruit disability-rich clinical sites or community sites where students can get some training, that will have a huge impact on outcomes. And finally, trying to influence healthcare training and healthcare at the state or national level by starting to change. And this is still a goal of us at the Alliance, to try to influence professional licensing and accreditation standards to require some disability content and competency. Okay. Very important to include people with disabilities in the planning of education activities. Take some time to establish relationships in the disability community, reach out through social media, word of mouth. I have some examples of where you can find groups of disabled people who may be really keen partners in this, and allow them to lead and have some ownership of the training. Also, students can be amazing advocates. We've seen some really powerful change happen at a national level because of a small group of disabled students started demanding it, and that people listen. Okay. I want to have time for conversation, so I'll just go quickly through some of the things that we've tried and look forward to answering questions and having conversations with you all. We created a seminar on global health that infused disability content, and it's part of a certificate program in population health for public health and interdisciplinary students. It's pretty popular. We have, for fourth year medical students, we have an advanced competency. So in their fourth year, they can have a deep dive into specific areas. We created an area, it's about a 4-week training on developmental disabilities. We didn't do this, but I've got to give props to the State University of New York at Buffalo. They created an elective thread. It's 4 years of content for their medical students. Has a really rich opportunities to work with disabled patients in clinic, in the community, and also in research. The next best thing is if you can require some content. We squeezed in a lecture during the first month of medical school on developmental disabilities. We also have 2 panels. One during their musculoskeletal unit, we have a panel of patients with mobility limitations who come in. We try to select people who will just shatter stereotypes that that the students have about their ability to contribute to society and have a family and have a good quality of life. And so that's been really effective. And we also have an autism panel. We bring in autistic adults and family members to talk about their healthcare experience. One of my favorite opportunities is a structured, formative, observed, structured clinical encounter, a FOSCE. So the students come in and each student gets to meet one-on-one with a person who's pretending to be a patient. This is a disabled person from the community who's volunteered to come in. Actually, they get paid, even better. They come in and they pretend to be a patient, they pretend to be seeking care, and the student is tasked with doing a brief medical and social history. And we can observe these encounters, and they get feedback from another student who's watching, from us, the faculty who are observing, as well as from the patient, on whether the encounter was comfortable, whether they skipped over things like the sexual history, whether they, whether what they did right, what they did wrong in the encounter. And then there's a group feedback that kind of debrief with all of the students. That's been really impactful. We evaluated outcomes a year later and found that experience, though brief, it had an impact on the students. Okay. The last bit of evidence, if you need to justify the cost of recruiting people with disabilities for your clinical encounters, there's strong evidence that engaging people with disabilities in the practice significantly improves outcomes for the trainees. A couple of citations there. And that's it. I really believe that we can intentionally include disability and disabled people in healthcare training, and that'll lead to a disability competent healthcare workforce. So that is my last slide. I will stop sharing. And I was going to try to keep up with the chat, but I cannot read and talk at the same time. So I apologize if I missed this conversation.
There's been some supportive comments about statements that you've said from personal experience, professional experience. I don't know, David, if Wilkinson, if you wanted to speak about your experiences at all, but he's supporting, he's seconding, he's seeing similar things in his practice.
Yeah. So have you, I know that at WVU, you've had some disability training, and you've recruited people with disabilities from the community to help with that training. How has that been for you all?
Melina, do you want to speak to Project Doc, and I can speak to some other things?
Sure. I was just going to say, we have one of the parent faculty from our project doc joining us today, Autumn. So feel free, Autumn, to jump in. But we have Project Doc, which is delivery of chronic care, which is offered to an interprofessional education opportunity to students in medicine, nursing, pharmacy, patient navigation, and a variety of other disciplines, nursing, several other ones come in and out. And it's on the medical home, and we have parent faculty who share their experiences in the medical setting pertaining to each of those disciplines with their children. Autumn, do you want to share? Let's see if Autumn is still. She may have had to step away.
Yeah, that's incredible. And have you had feedback from the students?
Yeah, so a part of that presentation is it's didactic. They have training materials that they review in advance. Then there's a didactic training. Then they break out into rooms where they get to interview two parents, and then they come back and the parents are put into a separate breakout room, and there's a debriefing that's facilitated by one or two of the physicians that are leading the training that day. And to hear the feedback, the immediate responses from the students on what they learned, and just how awakened they are to so many different things that they had never even thought about before, not just about patient care, but about how to work together with others and how other disciplines would work within that same lens. It's really great. And then we also have started to share a clip from that debriefing with the parent faculty.
Oh, nice.
Yeah.
Oh, that's powerful. And you mentioned that that's part of your interprofessional education program. I'm interested in that. At OSU, we're just starting a new program on interprofessional education. And as soon as I heard that they were trying to launch that, I got on the phone and I've been pestering them saying we have to have disability as part of this. You know, disabled people so need interprofessional care. It's a perfect case study. And so we've been talking about it and they're listening, but I'm really interested to hear how you've navigated that across different departments.
I think over time, word has spread and different departments have begun to come on board and really promote it as it's, over time started to catch on.
Oh, great. Good, I'm so glad. And the students, can you tell me a little bit about, so you have students from different programs in the same room learning the same content?
Yeah, Leslie, do you know the breakdown of what the years are in where that's offered as elective opportunities?
For doc,
Mhm.
on the medicine side, it's your MS3 and 4. No, I'm sorry, MS1 and 2.
Okay.
And then I think it's similar to the other disciplines in terms of an introductory piece, but then interestingly, the GME group on the pediatric side was particularly interested. And so you have that dichotomy of early in the training and then a little later in the training. But I don't necessarily think that that's matched across anywhere outside of medicine, is it, Melina, at this point? I mean, because they don't, I mean, it's different.
Yeah, I don't think it's a requirement outside. I was also encouraged to see some of the things that you were offering are similar to offerings that we have here at WVU. So we have the Not Your Standard Patient, which is the simulation that you discussed about the actors. And so we have something similar to that. We have the Disability Studies undergraduate program at WVU as well. So I think I picked up some ideas and then also kind of was happy to hear that we're on similar tracks.
That's so exciting. Really awesome. And I'd be really interested if you would take a look at the competencies and see if those align with what you've been trying to do.
I think one of the ways that Project Doc was added at the beginning, you're absolutely right in how you describe the process and the curriculum being full and all of that. But the team did that comparison of competencies and presented that to both the undergraduate and graduate councils before it even got started, showing.
Oh, you did.
And so absolutely.
Oh my gosh, that's so awesome. That you made my day. And that was exactly what we were hoping. By publishing the list, it would help guide people and convince them that they can do this. It's not that hard. You can just weave disability in.
Yeah, I love your idea about OSCEs and getting people involved with that. Before all of this started, and even now to a certain extent. So if we're just talking about, in the university setting opportunities, a lot of the simulation center that gives these experiences had actors.
Yeah.
Right. And so it's the same thing as kind of the media, right? You have someone acting like they have the disability and don't have it. And so I think over time with the groups Project Doc and some other things that on both sides, they've thought, well, we could recruit people, and then individuals with disabilities know exactly who to contact or path, because they know I'll do that. I'll be your, I forget what they call them. It's not actor, it's something else, but and that's gone a long way, so they could legitimately talk about personal experiences.
Yes,
So
and not again, kind of reinforce the negative assumptions about disability. If you have an actor who doesn't know anything about disability, how likely are they to say, oh, no, I can't drive, no, I can't work, I'm disabled. Come on, that's not real. Yeah, so I was told that it's called simulated patient if they're not actually pretending to have the disability, whereas a standardized patient, they're pretending to have a health condition.
okay. The other thing we haven't even started on here, and I see a lot of people representing outside of the university setting, right? So that getting them early on in their training is key. Continuing that, as you've mentioned, I really like your sustained pathway, that visual. I didn't get my camera out in time to take a picture, but I want to go back to it later.
Yeah.
But I think like David's talking about his experiences, and a lot of people have programs, they provide programs and services. Those providers too need that experience.
Absolutely.
You know, we run into like mental health needs, and counselors, social workers don't really have not been exposed to individuals with disabilities and think it's very different and really kind of stop.
Yes,
And so there's a lot of work in that realm too. So I think
absolutely.
what you're doing could be
I would love to do an interprofessional training opportunity with mental health, with social workers, psychologists, psychiatrists, as well as the rehabilitation therapists. I think that would be really powerful.
And ours have been just within health sciences, so it has not yet, although they've really wanted to get them in, and they might have already. Melanie could correct me, but social work is outside of health sciences here. So
Here
really
too.
anything outside of that has not yet been introduced, and that's what you're talking about too.
Yeah.
Does anyone else have any questions or comments or thoughts, experiences that you want to share? Quiet group. It's really sunny here today, and we're all maybe lulled because we have hot offices, or look it up.
I'm happy you're having a sunny day.
Yeah,
David,
right.
I've enjoyed your comments. I love that you're taking people with intellectual and developmental disabilities to the doctor, and totally agree that they're more similar than different. We had we had an acting group of adults with intellectual disability, and they put on plays and whatnot. We recruited them into our simulated patient group. Oh my gosh, they were amazing. They so loved the opportunity. I mean, they loved the opportunity to teach doctors, and to felt like they were playing a role.
Yeah, it gets frustrating. I mean, some of my people do need me to, speak for them, advocate for them, but I don't know how many times I've been on an appointment and the doctor's looking at me asking the questions, and I say, why don't you ask them?
Yes,
They're capable of answering your questions.
good for you. Yeah.
I'll tell an experience from a few years ago. One of the folks on my caseload was seeing his doctor, and his doctor would not permit his care provider in the room. And she said she should be there. And the doctor was sure she wouldn't. Well, when he recommended to the person on my caseload to quit smoking, the doctor got decked in the face. So these healthcare professionals may be inspired to pay attention to avoid getting knocked upside the head.
Oh my goodness. Yes,
After that, he let the care provider
he did.
into the
Okay.
appointments.
To his credit, he learned.
Yes.
Yeah, that goes both ways. There's healthcare providers who ignore the patient and only want to listen to a parent, and then, like you say, it can go the other way, where they think that they shouldn't have the parent involved. And really, they just need to listen to what the patient wants, what the patient needs.
Well, it's a little past 3. We can't thank you enough, Dr. Havercamp, for
Oh, yeah,
presenting.
thanks so much for having me. I really enjoyed this conversation.
Yes, absolutely. And I think there's many areas to collaborate. So more soon. We'll follow up.
Wonderful.
And
Great.
thanks to everyone for joining us on this sunny day. Please check back. We'll be here next month. And in the meantime, enjoy your afternoon. Thank you so much.
Thanks, everybody. Bye.